With the permissions of the organizers, uh, we begin the third day. So, on behalf of the entire team of ICanCaRe, IHBAS and Gujarat University, I welcome each and every one of you to the third day of the International E-Conclave on Tobacco Cessation. Welcome our Chief Patron, Rotarian Kalyan Banerjee, our Patron, Professor MC Mishra, Chairperson, Professor Dr. Nimesh Desai, and our Co-Chairperson, Dr. Rakesh Rawal from Gujarat University. I also like to welcome the entire organizing committee who have made this particular event, which a month-long event, divided into four sessions to be a fruitful event for effective implementation of tobacco cessation. I would also like to thank our supporters with whose help we could materialize this and make it a reality, make this event a reality. I would like to thank ISO, FHNO, Indian Chess Society, Delhi Psychiatry Society, CMHARTS, RAGAP, RSD Hospital, and IDS and Santosh University. I would also extend my gratitude to our pharma partners. We move ahead with the scientific session, so I hand over the dais to our Master of Ceremony, Dr. Nandita Divekar. Dr. Nandita Divekar is a consultant in anesthesia and critical care at Medway NHS Trust in UK, and she is the leader there for smoking cessation in her hospital. And she is very passionate about tobacco cessation, mostly smoking cessation, and has been pivotal in starting the stop before the OP clinics. And she has also been awarded for the CO award for the brilliance to study the Ottawa model. So I welcome Dr. Nandita Divekar to take this scientific session forward.
Namaste and thank you very much. Good morning, good afternoon, and it's good morning. It's a very beautiful morning here in the UK. And thank you very much, Dr. Pavan Gupta, Dr. Reena, and Dr. Nimesh, sir, for allowing me to moderate this session. Go on to our next session for experience with multimodal treatment in family practice. Our chairperson today is Dr. M.S. Bhatia, who is the director and professor and head of the Department of Psychiatry in University College of Medical Science and GTB Hospital, Delhi. He's been extensively involved in research and clinical experience in psychological problems, and he's been author for over 20 published books in psychiatry, neurology, psychology, and also more than 300 publications in all the various areas. He's won lots of awards for contribution in mental health, and his special interests include human relationship, consultation liaison, and a lot of other psychiatry and mental health issues as well. Welcome, Dr. Bhatia, and the podium is yours.
Thank you very much. So, as I congratulate the organizers for organizing this particular conclave, and I now request Dr. Pooja Patwardhan, who had experience of working in 3 different countries. He has been a very successful researcher, trainer, and also has a passionate in using innovative ways in tobacco cessation work. She'll be talking about her experience about the multi-modal method in family practice. So how it can be used, especially in different countries, for using in cessation the tobacco use, and also in preventing methods as a preventing method. So without taking much time now, I request Dr. Pooja to kindly continue with her presentation.
Firstly, thank you so much, Dr. Bhatia, for introducing me, and I'd like to thank Dr. Nimesh Desai sir and Dr. Pavan Gupta sir for giving me an opportunity to join this great venture you guys are conducting. It's amazing work and much needed. So, excuse me. So, as I said, I work in UK, and with my role as a family physician, I get to see a lot of variety of patients, from pregnant women. I do 6-week baby checks, mental health problems, COPD, asthma, angina. But unfortunately, very, very few people come to me asking help to quit tobacco. In UK, of course, it's mainly smoking when we talk about tobacco, but we do see some people, especially South Asian people, who use SLT as well, and then shisha and other forms of harmful tobacco as well. And when I proactively start the discussion about quitting tobacco, quitting smoking, the commonest answers I get are, "Oh, I know tobacco is harmful to me, doctor, but it's not the right time for me to quit. Life is really, really stressful currently." Or then some people say, "I've been using tobacco for a long time and it's not done any harm to me, so I guess it's fine for me." And then few others would say, "Oh, I've tried to quit genuinely, but nothing works for me. So it's just not my cup of tea." I'm sure few other answers you would have heard as well. And people give these reasons for why they can't quit, why they are not ready to quit. And in that case, we think about why do people, despite knowing it's such a harmful thing, why do they continue using it then, and why is it so difficult to quit, and why relapse rates are so high, and main and most important thing is, what can we do to support these people quit tobacco? Now, I must thank Dr. Vishal for uh, giving a brilliant explanation for this model. So I'm going to whiz through these slides. I had very similar things too, but I think it's good to see that so many of us are aligned on how we should support people in quitting. So as Dr. Vishal said as well, there are three important components of tobacco dependence. It's the physical component, the emotional component, and then behavioral component. So physical component, as we know, it's the nicotine addiction. So whether it's smoking or SLT use, the nicotine from that reaches the brain. It releases dopamine, which make people feel happy, stress-free for a short time. And then they keep on using tobacco, or in UK's case, mainly smoking, and they get addicted to it. They become dependent on it. When it comes to emotional dependence, we're talking about how people think they really, really need tobacco to just cope with their day-to-day stresses. They feel if they quit, they will just not be able to deal with regular days, activities, regular ups and downs in life, and it becomes a crutch for them. So they really worry about what would they do, and that's why they don't want to quit. And it's the behavioral dependence. So once people start taking tobacco on regular basis, they develop a pattern. Usually they start consuming tobacco with specific activities or at certain places. For example, we know alcohol and smoking, it's very commonly known association. Similarly, tea, coffee, and smoking, people often, when they go for a tea break, they would use a cigarette at that time. And also some people, they develop a habit. So every time they are waiting at a bus stop, for example, while going to work in the morning, they would have their cigarette. That's their routine. Or maybe if they're driving alone to work, that's when they have their cigarette, definitely. And that's a pattern. So if they've not thought about these associations, and if they try to quit, what happens is, whenever they are doing these activities, or whenever they are taking a coffee, or whenever they're waiting at that bus stop, they get sudden craving, they get restless, and they don't know what to do then. So it's that behavioral association and dependence we shouldn't forget when we are supporting somebody in quitting. And I'm saying the same line as Dr. Pawan said as well. It's allegedly Mark Twain said, "Giving up smoking is the easiest thing I can do because I've done it thousands of times." From a clinician point of view, I take it as a reminder for all of us that relapse is very, very common in tobacco addiction. And for us, we have to remember that, because we need to give self-help tools to every consumer, and we shouldn't just relax when they have managed to quit for 2 weeks or 3 weeks. We need to give them enough tools so that whenever in future they come across similar situation when they initially started using tobacco, whenever they started smoking or SLT use, they should have some tools so that they will not go back to that place again, and they will not relapse back. So it's something we need to bear in mind as clinicians, really. So what do we do? And again, I'm probably saying things which have been covered in the past talks today as well as in the previous talks, but it's good to revise so that hopefully all of us will remember. And this is from my experience, actually. If I just say to people, don't use it, it's really harmful, it's the wrong thing you're doing, what happens? It just gives a negative message. It's just nagging. There's nothing new. Most of the time, people have heard that either from other clinicians or through public health messages, and they probably want to quit, but no one has told them how to quit. And that's why they get that frustration, they get that guilt. It's just a lot of negative emotions. And it does affect the relationship between a clinician and the patient as well. So it creates that conflict, and no one wants to, the patient as well as the clinician don't want to go into that area again. It puts everybody off. And that's why it's important to, whenever we start discussions about tobacco cessation, we have tools to give to them to quit successfully. And hence, again, I'm probably revising few of the things which have been discussed. But when it's to tackle the physical dependence, it's NRT and other medications. When it comes to psychological or emotional dependence, it's the behavioral interventions. So with behavioral interventions in psychological and emotional things, it's the things that they can do for themselves to cope with the stress. As I said, it becomes a crutch. Often people use smoking as a crutch to cope with day-to-day stresses. So they need to think about how are they going to cope without that, and we should help them think about it. It's a bespoke thing, really, for everyone's life situation is different. Whether they have family support or not might be different for everybody. So we can't give a blanket solution to everyone, but we need to give them solutions which we should just encourage them to think about it. So, and in my personal as well as professional experience, tools which release endorphins, so mainly music and exercise, these are, I've seen they work for a lot of people. So, and with technology these days, it's really easy, especially in the last year of lockdown. People can access lot of variety of music, exercise classes, and interactive sessions as well, very easily from anywhere and everywhere in the world. So something we can give them as tool when they are in a stressful situation. And with the socio-cultural things, the pattern. So I again I ask them to think about things, what they're going to do when they normally use tobacco. So let's take the example of bus stop again. So if someone is used to smoking at a particular bus stop every day, see if they can take a lift for 2 weeks, maybe, just so that they just don't go near that bus stop, just to break that habit. Or see if they can walk to their office just for a few weeks. Can they not have tea and have some other cold drink for a few weeks, maybe? So they need to have this plan in mind about what are they going to do when they normally use tobacco, definitely. And if they have a plan handy, then when they get that craving, of course, nicotine replacement therapy and other medications would help with the nicotine craving. But the habit part, if they have got a plan, that would increase the success chances, definitely. And I would really like everyone to remember that withdrawal symptoms from tobacco don't wear off in a few days. Unfortunately, a lot of people who use tobacco, so consumers, but also clinicians, often think that it's fine. After a week, it's just their willpower. That's all they need, really. Anything they're saying, they're just making it up. Unfortunately not. You can see from this chart that many of really unpleasant withdrawal symptoms can last for weeks and sometimes even months. So whenever the patient has come to the stage when they are ready to quit, they've decided to quit, it's important we talk to them about these withdrawal symptoms, not to scare them off definitely, but to prepare them on what to expect. So it's when, and then also give solutions. So again, if someone's worried about constipation, we can easily give them laxatives for a few days, increase fiber, increase water in diet, simple solutions. But then they know that this is not long term, it will go, but at the same time they have got tools if they need to. And similarly, it's the safer nicotine in the form of nicotine replacement therapy. In UK, of course, we have electronic cigarettes as well, but in India it is banned. So, but you can offer nicotine replacement therapy to combat with some of these withdrawal symptoms. So remember, withdrawal symptoms are preventable, predictable, and treatable. And in today's times, we shouldn't let, just the way if someone's in pain, as clinicians, we should offer them enough painkillers. No one in today's time should suffer. And similarly, if someone's trying to move towards a healthier life, we shouldn't let them suffer as much as possible. It's our duty to offer them the choice, whatever is available, and as long as it's not contraindicated, offer them enough tools so that they won't suffer when they are making the right choice of quitting tobacco. So this is just about kind of a summary really about practical challenges that tobacco users face and then what we can do for that. So it's important that wrong beliefs and misconceptions, so for example, things like mental health effects of tobacco. A lot of people, as you know, think that it's actually a good thing for them. Mental health patients think that it's helping their mental health and they're surviving only because they are taking tobacco. But as we know, actually, tobacco in the long term worsens depression, it increases panic attacks, and quitting tobacco is as good as using an antidepressant. So it's important that we tell them the real stories, but as I said, we have to give them tools as well to cope with the time when they are in that quitting journey and lack of support. So enough support, individual support, and not just a blanket solution, because often it doesn't work. Everyone's life situation and reason for using tobacco is different. So giving them time, giving them empathy, it's really crucial. And if I've seen in some of the material in across the world actually that when people say you have to ask them whether they're ready to quit, and if people say no, they're not ready to quit, then we should just ask them to come back. But I slightly disagree with that actually. We need to find out why they're not ready to quit, because I've seen in my practice many a times people say they don't want to quit because either it's their own personal experience when they have failed to quit, or they've seen someone else who's failed. And as adults, no one likes to fail really. It's a natural thing. Who would want to keep on trying and then fail and keep on trying and fail? We need to give them confidence that actually this time we're going to give them enough tools, we're going to give them enough support to increase their success chances. And it's fine if they fail because we can try something else. It's important to tell them for different people, different tools work in different stages of life. So giving them enough tools, and also in the past talks we've seen important to talk about enough quantities of NRT, enough and the right technique of NRT. Often they might have failed because they probably were not using the right NRT or the right dosage of Champix or bupropion. They might have suddenly stopped it. They might not have tapered it down at the end of 12-week course. There are a lot of reasons why people might have failed in their past quit attempts. So I always feel, and I've seen that actually if we take some time out to find out why they have failed and why they are saying no now, many a times we can reason and then convince them to give another attempt to quit. And of course, we need to have enough clinicians. I completely agree with Dr. Gupta sir that we need enough people, enough clinicians who are trained to provide the right support, and we need to have enough support across the country, which is scaled and not just in one or two areas of country really. So and providing support throughout the quit journey, behavioral support, that's really important. Remember, relapse is very common, so self-help tools, and that case apps, how people can use single nicotine like NRT when they are at a risk of relapsing back, and where so how peer support, that's really, really important. If I tell you what services we have here in UK, is quite different of smoking cessation in the world really. Then most good things, I'm saying most, I'm sure other people like Dr. Divekar who are from UK, you would agree that we can do a lot more here as well. But some good things, we have NHS, which makes life really easy. So everything is free, and people can access free service for behavioral support through local stop smoking services, and they can get NRT from there. And the good thing is here we do encourage choice, patient choice. So people should be given, even in my practice, whenever a person is ready and they've chosen NRT as their quitting tool, I would always discuss. So one is a long-acting one, which is a patch. Then out of the short-acting one, this is the choice. These are the pluses. These are the minuses. What would you like to try? What would you like to quit with? And then tell them that they can always switch as well. So from gum, if they want to move to mouth spray, that's fine. Doesn't matter. It's not a prescription like antibiotic course where there is a strict regime. Let them adjust the dose as well. People who are smokers, they know how to adjust their nicotine levels. They're usually quite good at it. So if we give them the control, if we let them own their decision to quit, results are usually very, very good. And of course, we do have prescription medications like varenicline, bupropion, and some other ones which are not licensed for smoking cessation, but are used in practice. In UK, as I said, we do have electronic cigarettes as well. And in many stop smoking services, actually currently there are voucher schemes for electronic cigarettes to encourage more people to try and quit using anything. As we know, smoking is really, really bad, and any quit attempt should be encouraged really. App, it's a great thing in today's times. It gives us a very easy way to make things scalable, and in times like lockdown, people can access behavioral support, motivational tools through apps, which are fantastic. People can sign up for getting a daily email through the service, through the NHS Smoke Free service. So every day they get a ping, okay, what have you done today? This is what you're going to get. People have, there are apps which give them an idea of how much money they have saved every day and how their pot is increasing. So that's a very good thing. There are also peer support groups, either in the community, but also in today's times in social media. So in Facebook Messenger, NHS has a support group there, which again is a great tool. Peer support always in all other areas of medicine as well, we see it works really well. So that's something we do in UK. Now, I know these are a lot of cases. I'm not going to go into the detail of other medical problems. Just wanted to say to you, I want you to think about what's common. What is the common thing in history we need to ask for all these patients? And all these patients I've seen recently in my own clinic. So I've just picked up random cases to my clinic. One was a 6-year-old girl brought to doctor by parents with recurrent respiratory infection, wheezing.
Dr. Pooja, we will have to conclude actually if we are running out of time.
The last slide actually. I'll finish in a minute. Is that okay?
Yeah.
Thank you so much. Thank you. So yeah, recurrent wheeze, already had antibiotics, steroids, inhalers. 23-year-old university student. Worsening depression, panic attacks. 68-year-old coming for a pre-op checkup for his knee replacement operation. 52-year-old man coming for annual diabetes checkup saying, oh, very good, doctor, my blood sugar is very well controlled, and expecting a pat on the shoulder for that. 30-year-old housewife presenting with painless white patch on oral mucosa. So very diverse cases, different systems. Probably in India, I think all these people would go to different doctors, one pediatrician, one physician, probably a dentist. But I think the main thing we definitely need to ask all these patients, it's the history of tobacco use, history of smoking, and in some cases, history of excessive use. And that's because in many cases, the outcome would significantly depend on that. In some cases, that would be the cause as well. Why I've put these diverse cases is, again, to say that whatever your clinical specialty is, tobacco is such a big silent monster that it affects almost every organ in the body. And that's why it's every clinician's responsibility to get ourselves upskilled and then provide support in tobacco cessation, because very likely at least few problems coming to you are tobacco related, whatever is your specialty. So just concluding my today's talk. Quitting tobacco is not easy. So if patients are failing, it's quite normal. Unfortunately, keep giving support, keep encouraging them. Relapse is common, but give them tools and never give up. There are lots of different tools. We have to use combinations, dual therapies, but never give up, because something will work at some point, definitely. And as long as we provide patient-centric and comprehensive support, we are doing our duty as clinicians, because one of the best things healthcare professionals can do for their patients is to help them quit tobacco. Thank you so much.
Thank you, Dr. Pooja. She had successfully talked about the patient's beliefs. They lack beliefs, they lack knowledge, they lack support, they lack motivation. So how all the challenges can be overcome. And she also talked about the NHS model, and also the take-home message. The important one is that it's not easy to stop smoking. And another one, that it should be, treatment approach should be multimodal. It should be patient-centric. It should be patient-centric rather than the physician-centric or center-centric. It should be patient-centric and it should be comprehensive. And relapse is very common. So I congratulate Dr. Pooja for giving her a useful talk. Important one, she touched about the important point. And she has been the co-host also. I congratulate also Dr. Desai and his energetic team. And we already had more than 160 delegates who are participating in this particular program. So all the questions, they can be directed to chat box to Dr. Pooja, and that can be answered. Thank you very much, Dr. Pooja.
Thank you.
Thank you
so much. Thank you.
Thank you very much, Dr. Pooja and Dr. Bhatia, for this wonderful session.